So at ASCO, we heard the long-term results of a large prospective randomized trial, the Mindact study, utilizing the 70-gene mammoprint assay to help us identify or predict who may safely forego chemotherapy without impairing outcomes. So just a reminder of the design of this trial, all patients were assessed on the basis of clinical risk and genomic risk. If both assessments indicated a low risk, endocrine therapy alone was administered. If both assessments indicated a high risk, chemotherapy and endocrine therapy were given. And the discordant patients were randomized to chemotherapy or no chemotherapy, with all of them receiving standard endocrine therapy. The primary test population was the high clinical risk patients who had a low genomic risk assessment. And with the randomization, the investigators pitted anatomy against biology to see if we could safely spare those patients who, on the basis of ClinPath factors alone, the default would have been to offer chemotherapy. So I have a few takeaways. In terms of follow-up, more than 90% of patients were followed for at least 5 years, and more than 70% were followed for at least 8 years. And this is important because it highlights the point that we're dealing with a good sample size as we make these observations. Another takeaway for me was the inclusion of node-positive patients who by default are at higher clinical risk. This is something else which I think bears highlighting. As we know, the anatomic risk increases the risk of recurrence, but it doesn't necessarily change whether chemotherapy reduces that risk. Node-negative patients were also included. So this data set is extremely clinically relevant, I would say, as it reflects patients that we're routinely seeing in clinic, namely both node-negative and node-positive patients. The follow-up results presented indicated that the primary endpoint of DMFS continued to be met, and again reaffirmed that we can utilize this assay to identify patients who can safely forego chemotherapy. But what was particularly interesting to me was the median, at a median of 8.7 years follow-up, a 2.6% DMFS difference emerged in the clinically high, genomically low-risk patients who were treated with chemo versus those who weren't. When stratified by age, it was the women who were 50 or younger who garnered the benefit. This is very similar to what we saw in TAILOR-X, and it's hypothesized that this difference is perhaps not related to the cytotoxic effects of chemotherapy, but to the chemo-induced ovarian suppression, ovarian function suppression. And we know on the basis of soft and text that ovarian function suppression is very important, particularly in higher risk patients. So I would summarize by saying that I feel that these data confirm the clinical utility of this assay, and I feel we've come a long way from the one-size-fits-all approach. The use of genomic assays has really allowed us to individualize recommendations. In terms of the patient that I would consider utilizing the mammoprint assay, I'd just like to point out that in the Mindact trial, about 2/3 of the time, we were pretty good in estimating clinical and genomic risk in terms of concordance, but about 1/3 of the time, we determined a discordant result. So in my practice, I would certainly consider ordering it in a patient that's clinically high risk, particularly a node-positive patient, 1 to 3 positive nodes, someone who I was by default considering chemotherapy. But even there is the opportunity to consider ordering it in patients that you may not think could return with a genomically high risk, because we see that these data are helpful in informing decisions in that patient as well. So as Antonio Wolf pointed out, this whole concept of de-escalation in the discussion of the Mindact data at ASCO, I think this concept is very important because, as we know, although our intention is always to do the best for patients, sometimes our treatments are accompanied by toxicity issues that can be long-standing. So identifying the use of the use of chemotherapy in appropriate patients is of utmost importance, as it helps us spare patients risk who don't need the therapy. In my practice, I would consider using the mammoprint assay in any patient that I was considering utilizing chemotherapy. What I do think is interesting is in the Mindact data set, about 2/3 of the time we were accurate in predicting the genomic risk, meaning that there was a clinical and genomic concordance, either high or low, about 2/3 of the time. But 1/3 of the time we're discordant. So that actually highlights the need to consider ordering a genomic assay. But in my practice, it's interesting that as I've sort of started using the assay, I first really felt very comfortable actually in the node positive patients having prospective randomized data with the Mindact trial. Other exciting presentations at ASCO, there were many, but there are two that I would just like to highlight. The first is a phase 3 trial that was presented in the plenary session. It addressed the benefit of local regional strategies such as surgery and radiation in patients who presented with de novo stage 4 metastatic breast cancer. To give to context, there were previously 2 retrospective analyses, one from India and one from Turkey, that showed conflicting data in this for this question of whether or not local regional therapy will improve outcomes for stage 4 patients. So the data presented at ASCO showed that there was no benefit, and given the conflicting prior data, it was really important for us to definitively answer this question in a prospective, randomized, well-designed trial. But beyond the data that were presented, I think the other important point is that it highlights the need for us to be sort of equally excited about negative trials. Often we focus on studies with new important drugs that are changing outcomes for patients, and certainly those are exciting and needed. However, it's also important to clarify how we can use some of the existing tools in our armamentarium, such as surgery and local other techniques like radiation therapy, to improve outcomes for our patients. And this trial did help clarify those approaches. And speaking of new and exciting drugs, the other data set that I found particularly attention grabbing, and I think all of us did at ASCO, was the follow-up data on HER2 Climb with the use of tucatinib, capecitabine, and trastuzumab. PFS and OS benefits had already been demonstrated in the primary analysis and had led to the approval of tucatinib. The current data that was presented at ASCO really focused on the subset of patients that had brain mets. And this trial was really unique in that it allowed patients on that had stable and treated brain mets, but also untreated as well as treated and progressing brain mets. And it's those 2 latter groups that are commonly not permitted to go on clinical trials. At 1 year, the rate of CNS progression-free survival, which was the time from randomization to progression specifically in the brain or death, was 40% versus 0%, favoring the use of tucatinib. There was an overall survival benefit with a 42% reduction in the risk of death. So given that CNS metastases remains an area of unmet need for HER2 positive patients, these data were extremely exciting and hopefully will open up options for patients with HER2 positive metastatic breast cancer.